I walked into my first psychiatric clinical rotation thinking I knew schizophrenia. I had memorized the DSM criteria. I could list positive symptoms, negative symptoms. I knew my antipsychotics, Haldol, Risperidol, Clozapine. I was ready. Then I met my first patient. He told me the CIA was monitoring him through the hospital TV, and I froze. Because nursing school had taught me what schizophrenia was, but not how to actually care for someone experiencing it. If you've ever felt completely unprepared walking into a psych clinical, or you restudying for NCLEX wondering how any of this applies to real patients, this video is for you. I'm breaking down everything nursing school leaves out about schizophrenia care. Here's the problem with how nursing schools teach schizophrenia. They give you the clinical definition. They show you a chart of symptoms. They make you memorize medication names and side effects for an exam. But they don't prepare you for the moment when your patient is terrified because they hear voices telling them you're trying to poison them. They don't teach you what to say when someone insists their delusions are real. They don't show you how to build trust with someone whose brain is telling them everyone is a threat. Nursing school teaches schizophrenia like it's a checklist. But real patients don't present like textbook cases. And that gap between theory and reality? That's what we're feeling today. So let's start with the symptoms, because even here there's stuff your professors probably glossed over. Okay, you know the basics. Positive symptoms, hallucinations, delusions. Negative symptoms, flat affect, social withdrawal. But let's go deeper into what that actually looks like and what nursing school doesn't emphasize. First, positive symptoms beyond the obvious. Yes, auditory hallucinations are common. But did your professor explain thought broadcasting? That's when patients believe their thoughts are being transmitted out loud so everyone can hear them. Imagine thinking everyone around you knows your every thought. That's terrifying. Or ideas of reference, when patients believe random events are specifically directed at them. The TV news anchor is sending them coded messages. That car honking outside is a signal meant for them specifically. Why does this matter for nursing care? Because if you don't recognize these symptoms, you might think your patient is just being paranoid or difficult. But they're experiencing a very real, altered perception of reality. Now, negative symptoms that get misunderstood. Here's what nursing school barely touches. Negative symptoms often look like laziness or lack of motivation, but they're not. Avolition means your patient literally cannot initiate goal-directed activities. It's not that they don't want to shower or get out of bed, their brain cannot generate the motivation to start. Alogia is poverty of speech. Short, empty responses. Nursing school might mention it, but they don't prepare you for how frustrating it feels trying to have a therapeutic conversation when your patient can only give one-word answers. And here's the critical part. Negative symptoms are often more disabling than positive symptoms, but they get way less attention in nursing education. Then there are disorganized symptoms. This includes disorganized speech word salad, tangential thinking, loose associations. Your patient starts talking about their medication, then jumps to their childhood dog, then mentions the color blue, and you have no idea how those connect. Why does this matter? Because disorganized thinking affects their ability to follow treatment plans, understand discharge instructions, and keep themselves safe. You need to recognize it so you can adapt to your communication. So let's talk about that communication. Nursing school teaches therapeutic communication, like it's a script. Tell me more about that. How does that make you feel? But when you're dealing with delusions and hallucinations, those textbook responses just don't work. Rule number 1, don't argue with delusions. Your patient says the FBI is after them. Your instinct might be the reality test. No, that's not real. The FBI isn't here. But that destroys trust instantly. To them, it is real. You've just told them you don't believe them. Instead, acknowledge their feeling without reinforcing the delusion. Say something like, "That sounds really frightening. You seem scared right now. You're safe here, and I'm here to help you." You're validating their emotion without agreeing that the FBI is actually there. This maintains therapeutic rapport while keeping you grounded in reality. Rule number 2, redirect, don't engage. When a patient wants to talk extensively about their delusions, don't play along, but don't shut them down either. Gently redirect to something concrete and present. For example, if they say, "The voices are telling me the food is poisoned," you could respond, "I hear that you're concerned about the food. I watched the kitchen staff prepare it myself, and it's safe. How about we focus on your medication schedule for today? That's something we can work on together." Rule number 3, use simple, concrete language. Disorganized thinking means abstract concepts don't land. Instead of how are you coping with your symptoms today, try did you sleep last night? Have you eaten today? Are the voices bothering you right now? Short, direct questions. One topic at a time. This isn't talking down to them, it's adapting to how their brain is processing information right now. And rule number 4, establish yourself as safe. Paranoia means everyone is a potential threat. You need to be predictable and transparent. I'm going to check your blood pressure now. I'm putting the cuff on your arm. You'll feel it get tight, then release. That's normal. Narrate what you're doing. No surprises. No sudden movements. Build trust through consistency. Now let's get into medication management reality. Nursing school teaches you antipsychotic names and side effects for the exam. But they don't prepare you for managing those side effects in real time or handling medication refusal. You learned about extrapyramidal symptoms, or EPIS, but have you seen akathisia? It's not just restlessness. Your patient literally cannot sit still. They're pacing, rocking, tapping their feet constantly, and it's agonizing for them. Here's what nursing school doesn't emphasize. Akathisia can be mistaken for anxiety or agitation. If you don't recognize it, you might think your patient is just anxious and needs a PR and Ativan. But what they actually need is a medication adjustment or an anticholinergic like Cogentin. Then there's tardive dyskinesia, involuntary movements, usually of the face and tongue. Your professor mentioned it. But did they tell you it can be irreversible? That's why monitoring for early signs is critical, not just something you chart because it's required. And of course, neuroleptic malignant syndrome, or NMS. This is the emergency nursing school mentions but doesn't make you truly understand. Fever, muscle rigidity, altered mental status, autonomic instability. It's rare, but it's deadly. If your patient on antipsychotics suddenly spikes a fever and becomes rigid, this is a medical emergency. You don't wait. You don't wonder if it's just the flu. You escalate immediately. Then there's medication refusal. Here's the real-world scenario. Your patient refuses their antipsychotic. Nursing school says document it and notify the provider. But what do you actually do in that moment? First, find out WHOI. Are they experiencing side effects? Do they think the medication is part of a conspiracy? Are they afraid of becoming dependent? Ask them. I notice you don't want to take your medication today. Can you tell me what's concerning you about it? Sometimes it's as simple as, it makes my mouth dry. That's a fixable problem. Sometimes it's, I don't need medication, there's nothing wrong with me. And that's a nausea, a lack of insight into their illness, which is a symptom itself. You can't force medication unless there's an immediate safety risk and a legal order. But you CAN problem solve, educate, and involve the team to find alternatives. Let me give you 3 scenarios nursing school doesn't prepare you for and what to actually do. Scenario 1. Command hallucinations. Your patient tells you the voices are commanding them to hurt themselves. This is high risk. Command hallucinations with violent or self-harm content require immediate intervention. What you do, stay calm but take it seriously. Ask directly, are you planning to follow those commands? Assess their ability to resist. Have you been able to ignore the voices before? Ensure safety. Remove potential harm objects, increase observation, and notify the provider immediately. Don't minimize it. Command hallucinations are a psychiatric emergency. Scenario 2. Aggressive behavior during psychosis. Your patient becomes agitated, starts yelling, maybe throws something. They're not being difficult, they're terrified because their delusions are telling them they're in danger. What you do, maintain a safe distance and don't corner them. Lower your voice, speak slowly and calmly. Give them space. Offer choices when possible, like would you like to go to your room, or would you prefer to sit in the day room? Call for backup. If needed, never try to physically manage an aggressive patient alone. Scenario 3. The family doesn't understand. The family visits and says things like, just snap out of it, or you're not trying hard enough. They don't understand that schizophrenia is a brain disorder, not a choice. What you do, educate with empathy. I know this is really hard to watch. Schizophrenia is a medical condition affecting brain chemistry, just like diabetes affects insulin. Your loved one isn't choosing these symptoms. Provide resources like support groups and NAMI, the National Alliance on Mental Illness. Involve them in treatment planning when appropriate and set realistic expectations. Family education is a huge part of psych nursing, so here's what I want you to remember. 1. Schizophrenia isn't a checklist, it's a complex illness that presents differently in every patient. Know the symptoms beyond what's in your textbook. 2. Therapeutic communication with psychosis requires validation of feelings, not agreement with delusions. Build trust through consistency and transparency. 3. Antipsychotic side effects aren't just test questions, they're real, distressing, and sometimes dangerous. Monitor closely and advocate for your patients. And 4. Safety always comes first. Know when to escalate and how to intervene appropriately. Nursing school gives you the foundation. But real clinical competence comes from understanding the gaps and filling them with compassion and skill. Thanks for watching, and don't forget to like and subscribe for more real-world nursing tips.